Good morning, everyone. Welcome to the Fight Colorectal Cancer webinar. My name is Sharon Worrell. I am the Senior Manager of Education and Research here at Fight Colorectal Cancer, and so glad that you're able to join us today. Our webinar this morning is about GI ASCO, the conference that just took place last week, and we'll be recapping the conference and the highlights around colorectal cancer that were discussed. So today's webinar, if you have questions you can ask questions in the panel on the right side of your screen, and we'll address those questions as they come up. You can watch a recording of this webinar on the Fight CRC website. Following the webinar, you can visit fightcrc.org. In addition, if you're on Twitter, please follow along using the hashtag CRCwebinar. Fight Colorectal Cancer offers a wide variety of resources for those touched by colorectal cancer. Visit fightcrc.org to view, download, and order the latest resources. The information and services provided by Fight CRC are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you are ill, see a doctor immediately, and in an emergency, call 911 or go to the nearest emergency room. Fight CRC never recommends or endorses any specific physicians, products, or treatments for any condition. Our presenter today is Dr. Axel Grothey. He is the Director of GI Oncology Research at West Cancer Center, University of Tennessee in Memphis. He has been a medical advisory board member of Fight CRC for quite some time, and has quite an impressive work behind him. And we are so thrilled that he's with us today to talk about GI ASCO and talk about the latest breaking research. And with that, Dr. Grothey, thanks so much for being here. I'm going to let you take it away and present to us this morning.
Yeah, thank you so much. And I'm going to share my screen here. Just bear with me for a second. Okay, here we go. Yeah, thanks for allowing me to provide some insights on, what happened at ASCO GI last week. And I'd like to actually put this into a larger perspective in what I believe is where we are going with colorectal cancer. And there you'll see that my presentation has different parts. And I would encourage you to ask questions, as much as you can. And I know these questions will be curated and we'll address them after each of these separate parts that I will present. So when we talk about goal of medical therapy in GI cancers, in colorectal cancer specifically, it's really finding the right treatment for the right patient at the right time. I think it's as trivial as it sounds, it's sometimes not that easy to embrace because it's really one size fits all doesn't apply anymore. We need to be more granular. And I do believe that individualized therapy did not start with molecular profiling, but molecular profiling, liquid biopsies, etc. There's a lot of interest right now, and I will spend the first part of my presentation on exactly that topic, which I know from Twitter communications is one of the most interesting ones that people are discussing right now. So just a little pun, new ideas in the adjuvant setting, and I'll want to focus on the adjuvant setting, curative setting. What do we do after resection of a patient with stage 2 or 3 colon cancer, meaning not metastatic, but a setting where we discuss the use of adjuvant chemotherapy as prophylactic chemotherapy. Of course, there's immunotherapy. We all want immunotherapy to work in patients. And we, in the MSI high mismatch repair deficient cancer, stage 3 actually, which accounts for, in this setting, about 8% of patients, we have an ongoing randomized trial in the United States, the so-called ATOMIC trial, FOLFOX plus minus atezolizumab, which is an immune checkpoint inhibitor, a drug that can activate the immune system. That's actually ongoing right now. I think a critical issue really is the idea of using circulating tumor DNA, liquid biopsy, as marker of minimal residual disease to select patients for treatment where we would normally not treat, or not treating where we would normally treat. And I'll come back to these different scenarios in a little while, because I believe circulating tumor DNA will be able to change the way how we identify patients for adjuvant chemotherapy, for additional chemotherapy after surgery. Stem cell inhibitors, question mark. I don't think this is ready for prime time. But those of you who followed the idea, the results of the so-called Beacon study, which I'll highlight in a minute, you know that there are now drugs available to target a certain subpopulation of colorectal cancer with the BRAF V600E mutation. And we are trying to move these agents into the adjuvant therapy setting to hopefully cure more patients with colorectal cancer. Now, clinical application for ctDNA, and this is the liquid biopsy that we're talking about, are can be found in various areas. I could envision that at some point in the future, in terms of cancer diagnosis or screening of a population, we'll just have, let's say, one blood draw a year, and we'll get screened for colon cancer, lung cancer, pancreas cancer, breast cancer, cervical cancer, etc., just with this one blood draw. This would be it would change the way we really diagnose and screen a population for cancer. Now, the main issue I would like to talk about is so-called minimal residual disease. The problem that we're facing when we identify patients for adjuvant therapy after resection of a primary tumor in the colon is most patients actually cured by surgery. This is really the most important step. But we know that there is a risk of recurrence, and the question is, we use pretty crude markers, prognostic markers, to identify patients who are at higher risk of recurrence. And those patients, then we offer chemotherapy, prophylactic chemotherapy, to potentially kill these microscopic cells that could have flown off into the body and would eventually generate recurrence of disease. And we like to kill these micrometastases. So what if we could identify if there is, with a higher likelihood, with a higher sensitivity, whether or not there are still some microscopic cancer cells in the body? And this is this idea of minimal residual disease, utilizing technology that has emerged over the last years that is highly sensitive to pick up cancer fragments, cancer cell fragments, DNA fragments in the blood of patients. So this is why we're talking about circulating tumor DNA. So tumors, as well as other cells, release these small DNA fragments which have a very short half-life. So the presence of a mutated, meaning cancerous looking, circulating tumor DNA indicates there's something going on. There might be, or there's very high likelihood, and I'll show you the data later, there's cancer still left in the body. So this is something we've known for quite some time. For the last 5 years, we have run interesting studies to figure out what is the meaning, what really is the clinical relevance of these liquid biopsies and circulating tumor DNA. Now, the circulating tumor DNA, when you look at the commercially available tests, and there are various tests available, which I'll highlight in a minute, it can be mainly broken down in two different types of tests. One is so-called tumor agnostic. What does that mean? So we know that colon cancer commonly has certain mutations, for instance, in KRAS, in BRAF, in APC, etc. So we know there are certain mutations which are very common in colon cancers, and we could develop a test, a screening test for the general population of cancer patients that really looks at, let's say, 20 of these genes, which we know are commonly mutated, commonly altered, and we just have a one-size-fits-all test for, to screen colon cancer patients after tumor removal. And this is, for instance, this LUNA-1 assay from Guardant. That's a next generation, so highly sensitive panel or PCR panel that's which really tries to screen all patients more or less with the same test for these mutations. There's another test called Vera, which is also not individualized, so it's a one-size-fits-all, which makes it easy to apply. It's a kit that we can use. The problem that we know is, whenever you develop a one-size-fits-all test, it has a lower sensitivity because it's not really made for each individual patient's tumor. Now, the other way to develop the ctDNA test is a tumor-informed test, meaning we take the tissue of the cancer that's been removed and really figure out in this very patient individualized what mutations do we find, and then develop a highly sensitive test that is only being used for this one patient, not just once, but longitudinally at several different time points over time. And This then generates a test with very high sensitivity. Now, since we need to develop this test upfront for each individual patient, him or herself, it takes a little bit of time to work up the cancer. So there's a little bit of a lag time, but normally the turnaround time from sending this tissue in to having a blood test for this one patient available is about only 2 or 3 weeks. So it really can be applied to adjuvant therapy, meaning post-operative treatment. So this is a higher test which has higher sensitivity. All these tests that I mentioned, there are other tests, so this is just an example. Don't consider this an endorsement of one or the other tests. These are being used in clinical practice right now. Why we're so excited about this? This is the pivotal paper, an Australian group in conjunction with Johns Hopkins, published about 4 years ago in patients with stage 2 disease, meaning not lymph node positive disease, where we normally do not give chemotherapy. We don't give chemotherapy in all these patients, so low risk. If the investigator saw circulating tumor DNA positivity about 4 to 6 weeks after the tumor resection, there was a 100% risk of recurrence. I mean, again, these patients who had this positive test, and this were only about 10% of patients, 8 to 10% of patients, those patients had a 100% risk to have recurrence of their cancer within 3 years. And, even when and this was actually more important than the clinical risk factors, clinical high risk, clinical low risk, the other parameters we take into account when we look at cancers, like was there perforation, was there lymphovascular invasion, so all other parameters we looked at. Even if we've separated patients out by that, still the presence of this circulating tumor DNA, a positive liquid biopsy, was highly predictive of recurrence. Now you can break it down like this here in this chart. So if you had a positive CTDNA after the tumor resection, which only happened in about 8% of these patients, but 8% is not trivial, the positive predictive value, the likelihood that this test could predict recurrence within 3 years was 100%. The likelihood that it eliminated, so it predicted no recurrence, meaning the sensitivity for a test saying, you will not recur when you have a negative test, was 91%. And these are test characteristics which are quite remarkable, because it's hardly anything that we see in medicine that has such high positive and negative predictive value. Now, the key point that we didn't know at this point in time was, if you have positive ctDNA, can chemotherapy prevent recurrence? Or is this a point of no return, meaning whatever you do after, if you have a positive test, the tumor will recur anyway? So these are data actually, again, same group, which were published this year, or actually last year, which I think are very, very critical. So in patients who received chemotherapy, and this is now stage 3 colon cancer, meaning where we normally offer patients chemotherapy, like FOLFOX or capecitabine, oxaliplatin, Xelox, if patients had positive ctDNA, meaning liquid biopsies, yes, they were not doing as well as if they had a negative test. But as you can see on the left-hand side, the gray curve, these patients did not all have a recurrence, meaning we could save about 50% of these patients from getting a recurrence. And this is, I think, a very critical point. So there is a consequence if we see circulating tumor DNA positive, and it's a situation where we normally would not treat, we should treat, because we can make a difference in these patients. And this can slice and dice in different ways. And so the bottom line is, yes, we can save patients from a recurrence if we give adjuvant therapy, if we give chemotherapy in these patients. This ties into the Kobra study here now. So this was actually, which was presented at ASCO GI last week. Dr. Van Morris, from MD Anderson, who's the lead of this national study. It's a large study, which looks at how can we convince people that circulating tumor DNA is the way to go in a situation where we would normally not treat. So here is, this trial focuses on patients where with a low risk stage 2 situation, so where we would normally not give any chemotherapy, and rightfully so, but those patients will be randomized to either be tested for circulating tumor DNA, and then if they're positive, they receive chemotherapy. If they're negative, they go to observation. And this is the critical point. Or standard of care right now is we don't use this information, and patients will eventually, these patients who don't get the tests done, the blood will be batched and analyzed later. And later we will actually see, is this information to have a CTDNA test able to improve patient outcome when we select those patients with positive circulating tumor DNA for adjuvant therapy. And the study was actually activated last month, so it is open. I have not seen any patients on yet. I hope it's going to accrue quite rapidly. So this is a situation where we use the information of circulating tumor DNA to select patients for treatment where we would normally not treat. And that's pretty easy, because I think it's very intriguing, of course. Now, the question is, of course, what if you have a patient with a stage 3 colon cancer, lymph node positive disease, and you have a negative ctDNA test? Would you not treat, or would you de-escalate? And this, of course, requires a very different ethical calculation, because what would be withholding treatment mean? And are we really sure that negative ctDNA really means no cancer? And this is actually something we're discussing right now, again, in international collaboration. If you really want to make sure that we're not harming patients by withholding treatment, and I don't want to go into the schema of this study design, which is very preliminary. If we want to make sure that we're not harming patients by withholding therapy in negative ctDNA situations, we need to have a very large study, probably 10 to 15,000 patients, which can only be done, again, in a pooled analysis. Now, in an international analysis. Now, the other question that was actually discussed on Twitter, and those of you who follow me on Twitter, there's a lot of discussion right now on liquid biopsies, etc., is what if we not give adjuvant therapy if we see negative ctDNA, but test sequentially, let's say every 2 to 3 months, and only give treatment when we see this test turns positive, meaning there is an emergence of microscopic clones of cancer, and we do give chemotherapy only for those patients who need it, and not everyone, one size fits all. This is, I think, a very important question that is being addressed. So circulating tumor DNA, liquid biopsies is a huge area of huge interest. And I would actually like to pause a little bit right now to see whether there are any questions that you might have for the trial designs that I just mentioned, the Kobra study, which I'll just put up here again, or the usefulness of liquid biopsies. And I actually don't know how to see these screens. No open questions. Okay. So again, I would stop for a second and solicit questions. Are there any questions you might have toward this issue?
If anyone has questions, on your screen at the top, there's a tab that says Q&A. And if you click on that tab, you'll be able to input your question, type it in on your screen, and we'll see it on our end. Okay. Otherwise, we'll also have time at the very end to kind of go back to that. So I'll probably, oh, here's a question that popped up. For crossover in the Kobra study, no, I mean, so, and Manju, hi, good to hear you. Good to, actually, you were at the meeting last week. No, crossover in Kobra is not allowed. So it's really the idea that patients who were with the standard of care, which is observation, their tests will not be made available until the end of the study to really serve as control group for the overall analysis, whether we can have a benefit in terms of delaying tumor recurrence or curing patients over time. So there's no crossover. Then the next question is stage 3 colon cancer. Treatments, so circulating tumor DNA will be used or is being used in stage 4 colon cancer to guide treatment decisions. And I personally, for instance, use it
at various points. Number one, when I need to have a very fast test, the turnaround time of liquid biopsy is about 5 working days compared to, let's say, tissue-based tests, which can be up to 2 weeks, and we need a biopsy sometimes to get fresh tissue. So I use it in the initial workup of stage 4 patients, and I use it also to guide some treatment sequences, in particular when I'm thinking about re-challenging the cancer with EGF receptor antibodies like cetuximab and panitumumab, because we see resistance markers emerge in these liquid biopsies, which can then guide our treatments. There was a study from Italy about a year ago, the so-called Cricket study, which really showed that this could be helpful to identify patients who can or cannot benefit from re-challenging with EGF receptor antibodies. In stage 4 colorectal cancer for recurrence, I mean, this might actually relate to patients who might have resected liver metastases, where, we think, they might have a chance to be cured. Yes, there are data out there that the emergence of a positive CTDNA in liquid biopsies does predict for recurrence, which is exactly very similar to what we saw in the earlier stage disease. The study that's being planned, mind you, the study that's being planned right now, the international collaboration stage 3, is undergoing so many different iterations. And yes, very clearly, there is, in this setting, there is crossover planned. And actually, there's planned for sequential testing and treatment when the CTDNA turns positive, which is more or less a crossover. Maintenance chemotherapy after resection. So in stage 4 disease, when we talk about how long should we treat, I normally do not go beyond the 6 months perioperative treatment. I'm not a fan of maintenance therapies in a resected non-evidence of disease setting. I'm a fan of maintenance therapies when we have active tumor or tumor present that we can visualize on scans, because I believe as long as cancer is present, we should have some form of anti-cancer therapy to really turn this cancer into chronic disease. Now, the idea of using some form of treatment, continuous treatment in patients who have positive circulating tumor DNA is intriguing. I've not done that yet because we are just scratching the surface of the circulating tumor DNA, but it's definitely something we might have to consider. In particular, also, we need to integrate ctDNA tests in virtually all the studies that we're running right now, and this could be a question that actually comes up. Natalia, about ctDNA, good option of patients where primary solid biopsy failed. Yes, that's definitely something where I use, where I use circulating tumor DNA. And Gwen, very nice to see you that you're on. Really nice to see you. It's supplement MR scans that aren't diagnostic. It's interesting. This goes beyond the adjuvant therapy here. It goes toward the prognostic indicator of the ctDNA levels in general. So ctDNA gives us 2 information. Number one, mutations, and the alterations, MSI status actually in the Garden test, for instance. But it also gives us some information about the actual tumor load, because there's a quantification how much of the DNA which we can find in the tumor in the blood of patients is actually tumor DNA. So there is a readout in terms of how much cancer is there, which is kind of an augmented CEA tumor marker level, much more specific, of course. So yes, it can be used to really get an idea about how much cancer is there, especially if we use it longitudinally, and can follow patients over time with their circulating tumor DNA. I think there are more questions. Oh my God, yeah. I don't think that every patient with stage 4 disease needs a circulating tumor DNA done. I do believe that every patient with stage 4 disease needs to have molecular profile of their cancer. And there are different, let's say, levels of how aggressive we can be. I mean, you definitely need to have a RAS and BRAF test, MSI tests to see whether immunotherapy can work. I also believe HER2 testing, is important, because all these tests are linked to treatment options for patients. And it's very clear, the more options we have for patients, the better it is. So that is something which we definitely want to see. And circulating tumor DNA can be used for that. It is, but normal tumor biopsies, of course, would also be used for this. Okay.
Thank you so much for all your questions. I think we can continue on, and if more questions come up about ctDNA, we can address those at the end.
Yeah. Yeah, last one question, because Manju just talked about this. Chemotherapy can clear ctDNA, yes. And we see so we would we see more ctDNA levels, for instance, when tumors progress. And yes, some cancers like peritoneal disease and mucinous cancers are not as prone to shed the ctDNA. So yes, there are certain clinical situations where the ctDNA yield is not as high. Okay, let's move on. There's a lot to talk about, and it's quite interesting. Let's talk about BRAF mutation. And just to look at this cartoon diagram, BRAF mutations are not uncommon in colorectal cancers. I would say it's about 8 to 10%, depends on the population that we're looking at. And this BRAF V600E mutation, which is the most commonly found mutation, is associated with very poor prognosis. And the cartoon on the right-hand side is really kind of a simplifying of molecular biology. There's an EGF receptor on the surface of the cancer cell, which we can actually target with antibodies like panitumumab and cetuximab, so Vectibix and Erbitux. And we're trying to shut down this pathway inside the cell, and this pathway means what we call signal transduction. There are signals activating cancer signals that the cancer cell uses, and all these different, let's say, bubbles here, RAS, RAF, MEK, and ERK, are proteins which are either on or off, and on means the pathway is active, off means it is not active, and on can drive cancer. And this is really what it is. So we have blockers of this BRAF and MEK and ERK and EGF receptor. So what if we just use one drug like encorafenib, for instance, or vemurafenib, and just block this activated pathway in these patients with BRAF mutations? The cancer cell, however, upregulates the whole signal pathway again, so it overcomes the blockade through a feedback loop. So what we really need to do is block this pathway in two ends. We need an antibody against the EGF receptor, and we need a BRAF inhibitor at least, and we can potentially even add a MEK inhibitor, which is the protein below BRAF, to that, and form a triplet regimen without chemotherapy. And this is really the rationale to use this Beacon regimen, which was published in New England Journal just recently, was updated actually with a very important analysis by Scott Kopetz last week. So this is the idea: can we use biologic agents that really target this pathway that I just showed you, encorafenib, the BRAF inhibitor, cetuximab, which is the EGF receptor antibody, which is Erbitux, and perhaps a MEK inhibitor for this, to block this activated pathway. And this was a very large international collaboration of looking at a triplet treatment, a doublet treatment. These are the two experimental arms that really try to use biologic agents without chemotherapy to improve survival for cancer patients with this BRAF V600E mutation, or a control arm, which is old so-called standard of care of irinotecan-based chemotherapy with cetuximab. So this was a large study, more than 600 patients. The highlight was really that it improved overall survival. So compared to the control arm, the triplet or the doublet, triplet on the left-hand side, doublet on the right-hand side, improved overall survival. It actually decreased in the likelihood to die during the study for patients by almost 50%, which is the largest difference we've ever seen in a trial in colorectal cancer. Since, oxaliplatin doesn't have as good data, irinotecan doesn't have data of that quality, bevacizumab, cetuximab, all the drugs we're using have never shown as much of a dramatic benefit as the triplet and the doublet. Now, response rate was 10 times higher, as you can see on the bottom of the screen. But the unanswered question was really, do we need a doublet? Do we need a triplet, which includes this MEK inhibitor binimetinib, or just a doublet, which is just encorafenib and cetuximab, particularly since the side effects of the triplet were higher. And the doublet, of course, is much less expensive. There's one new agent less, which of course decreases costs. Now, the presentation at ASCO GI last week had two important features. Number one, quality of life. And I think this is a very, very critical point that we should be more and more intrigued about. Is it's not just survival time, but it's also, can we improve or can maintain quality of life on patients? And unfortunately, in cancer, in stage 4 disease, the cancer itself can take a toll on quality of life, in pain, lack of appetite, etc., etc. And the combination of the biologic triplet or doublet, the BEACON regimen, were actually able to delay the time to deterioration of quality of life. And this, I think, is a very critical point. Patients were able to have better quality of life for a longer period of time when they were on the experimental therapy, on these biologic agents, encorafenib and cetuximab, or encorafenib, binimetinib, cetuximab, compared to the standard chemotherapy-based treatment regimen. So these data are pretty convincing in my eyes, and they're different subscale. This is the ERTC scale, this the so-called FACT-C scale. They're testing different quality of life measures, and it's a composite score. It's not just one question. There are various questions that are embedded in this questionnaire, but consistently, doublet and triplet both improved or kind of delayed the time to deterioration of quality of life. So patients who were on these drugs had longer maintenance of quality of life. Now, critical for the discussion about do we need a doublet or a triplet is this analysis here. And is actually, I compliment the company to put this in, because the abstract was really only written for the quality of life analysis, but right before ASCO GI, we actually saw the data that convincingly show that with longer follow-up time, there was no difference in outcome between triplet and doublet. Meaning, patients who were receiving just encorafenib, cetuximab had the same survival as patients who received the triplet. Now, the study formally did not want to compare triplet versus doublet, but when we saw the data, it was quite convincing that everything we need to move forward on is really related to the doublet. Less toxicity, less cost, and the doublet is kind of the new standard of care for patients with BRAF V600E mutant tumors in the second and third line treatment. But this is combinable with chemotherapy. So when we talk about moving this, for instance, into the adjuvant setting, early stage setting, we can easily do FOLFOX plus this biologic doublet combination. And this is likely moving forward into a larger phase 3 study. I don't want to go into the subgroup analysis here, but just give you an idea about the safety profile. You see that this is the more serious events, triplet versus doublet. Doublet has less diarrhea, really less vomiting. There's binimetinib, which is part of the triplet, has some cardiac issues and has some blurry vision issues. So the doublet, I'm very happy to see that the doublet is the way to move forward, which is even better, clearly better tolerated than even than the standard chemotherapy. So this is what I wanted to talk about, the BEACON study in the BRAF mutations. So, and I'm wondering whether we could stop for a second and allow you to ask some questions. And I look at here, it's, so the, okay, live preliminary. So, okay, so for Natalia, the question of BEACON trial and wild-type, BRAF wild-type tumor. So the BEACON regimen only works in BRAF mutated settings. It does not work anyway in wild-type tumors. And so the key issue that we're looking at right now is, the BEACON data show very interesting that the drug, this combination works, but it only works that long. So we are still not curing patients. So the next step in our research will be to identify why are patients progressing? Why are tumors not responding anymore over time to this beacon regimen? And do we need to add different, targeted agents or chemotherapy to the treatment, for instance, the doublet? And that would be quite intriguing. This is again where circulating tumor DNA can be helpful over time to really identify, when patients show growth of their cancer, what is happening and why are these tumors growing? What is the resistance mechanism? So that is something which is really going to be keeping us busy over time. Again, wild-type tumors, it doesn't work. Wild-type tumor, BRAF wild-type tumors would not respond to the beacon regimen at all. And I would not be able to, really provide input about specific, cases that I see being asked right now. I think this is something that really requires a very different forum. Okay, I think we can move on. Sharon, should we move on?
Yeah, let's go ahead and move on. And again, if we have time at the end, we can continue to address questions. So feel free to continue typing them in as they come up for you, and we can address them later on in the presentation. Thank you.
Okay, very good. So one part of the discussion that I'd like to have now is about immunotherapy in patients up front. So you're quite familiar, I'm sure, that immunotherapy is the big issue right now in all of oncology virtually. That in colorectal cancer, though, it's only a fraction of patients that really benefit from at least current immunotherapy, which are these patients with the MSI high mismatch repair deficient tumors, which only make up about 4 to 5% of metastatic disease, so stage 4 disease. And we know that these immunotherapies like pembrolizumab, Keytruda, nivolumab, which is Opdivo, ipilimumab, these drugs work in a later line setting, but what if we, after patients have gone through chemotherapy, what if we use those drugs early on, right up front when patients get diagnosed with stage 4 disease? And we don't have a lot of data on that. And Heinz Lenz from USC keeps kind of representing data and giving us more long-term information about his 45 patient cohort, which are generate very intriguing data with a combination of nivolumab and ipilimumab, so augmented immunotherapy with 2 immune therapy drugs. So, we like to look at waterfall plots. And this is, every single patient of these 45 patients is represented here. And you can see that 84% of patients had a reduction in tumor burden from baseline. And some patients actually had a complete response. And that is quite interesting. Now, there are a few patients who have progression of disease, who kind of interestingly did not respond and actually showed tumor growth. And this is a phenomenon which we are a little bit worried about because we don't know exactly who these patients are. And there are reports in other cancers, like in lung cancer, for instance, that immunotherapy can actually paradoxically increase the growth rate of cancers in very few patients here, as you can see. And we still need to figure out who these patients are. We need to be quite careful about that. Actually, this is another area where circulating tumor DNA could help, because there are data that the responsiveness of cancers to immunotherapy can be easily checked with the level of how much circulating tumor DNA, how much positive liquid biopsy is really present in a patient's blood. Now, the question here is now, how let's say stable are these responses, and what's the long-term outcome? And this now is exactly what he showed, in the updated analysis last week. And you can see that for progression-free survival and overall survival, there's a plateau. There is something to be said that these patients do not have progression of disease. And we even believe there might be some patients with stage 4 disease who could be cured with just immunotherapy, which, it's always difficult to really use this word cure, because it's kind of you only know, let's say, later on whether cure really happened or not, but it's very intriguing to see that patients don't have progression of disease for a long, long time. Now, we do not see this with chemotherapy. We just don't see it. And I can show you a comparison. So these are this is the progression-free survival curve of Heinz Lenz, meaning really from first line on. On the right-hand side is the pretty recent FIRE3 study, which looked at FOLFIRI, cetuximab versus FOLFIRI bevacizumab, and that's progression-free survival. When you just cut it off at the 24 months range, you can see the left-hand curve versus the right-hand curve. There's no comparison. So it's very intriguing to see, first-line immunotherapy for MSI-high tumors. Is this the standard of care? Now, this is a 45-patient non-randomized study which shows these interesting results. There are actually randomized studies ongoing, the so-called COMMIT study, which is a collaboration between NRG and SWOG, a US study, which was initially a 3-arm study. It's not accruing as well, and the atezolizumab middle part is actually being dropped right now. It's being redesigned. There's actually a completed study, the so-called Keynote 177 study, which looked at pembrolizumab, meaning Keytruda, upfront in patients with MSI-high tumors, and the control arm is dealer's choice of chemotherapy, whatever investigators wanted. And the study has finished accrual actually quite some time ago. The good news is the events, meaning progression events, survival events, are not coming in because patients are doing so well on the study. So we'll probably have to wait a little bit longer to really have a randomized comparison in these patients with upfront immunotherapy, again, which I find very, very intriguing. Now, as you know, the immunotherapy only works for these 4 to 5% of patients with mismatch repair deficient or MSI-high colorectal cancer. There has been a lot of interest in generating, let's say, an augmented immunotherapy approach where patients who don't have these features, mismatch repair deficient colorectal cancer, respond to immunotherapy. And one of the most interesting and heavily discussed combinations, that makes immunotherapy work in the vast majority of patients potentially work, is the regorafenib nivolumab combination, which was presented at ASCO last year and actually updated ASCO GI by the Japanese group. So they looked at, 25 patients with colon cancer and 25 patients with gastric cancer who had received several lines of chemotherapy and were kind of, didn't have a lot of treatment options anymore. And they used low-dose regorafenib, 80 milligrams, and nivolumab at a standard dose. And they showed 35% responses in patients with colorectal cancer and a similar response rate, 40% in patients with gastric cancer. In gastric cancer, even in patients who had received immune therapy and were refractory to immune therapy, meaning had progression of disease, when the regorafenib was added, they showed a response. Not in all patients, of course, but the data we have seen here, and again, which were updated at ASCO GI with a summary here. So they identified the optimal dose, limited adverse events, and I'll come back to that in a second, that in a later line setting, the 1-year progression-free survival rates and overall survival rates were quite intriguing. I mean, we have about 40% of patients with this treatment, 25 patients with colorectal cancer, not having any tumor growth after 1 year in a setting where we normally, see a median progression-free survival of about 2 months. That is clearly intriguing. Now, the side effect that the investigators saw, and and this combination is now being used off-label more or less in a lot of patients actually, outside of even of clinical trials, is mainly immune-related rash, a whole body rash, which can require dose reduction or even the use of steroids, like prednisone in patients to counteract this immune rash. Now, I would not, and this is very critical, I would not endorse the use of regorafenib and nivolumab off the cuff, outside of a clinical trial. There are clinical trials ongoing, there are clinical trials in planning. This is very intriguing data. I know there's a lot of interest about this, but it's not ready yet for prime time for all patients with colorectal cancer. I think that's a very critical point. It's Japanese data. We need to replicate these data in a Western patient population. Most of the responses the investigators saw in this study, which they admit to, were in lung metastasis, not in liver metastasis. And we know that liver lesions are the main issue that colorectal cancer patients face, not necessarily lung metastasis. So I would be hesitant to really think, this should be done now in every patient. Okay, I'd pause here and would like to field some questions. So one point, I mean, Stan put a patient on with a BRAF G469R mutation. This is not the right mutation for Beacon. Beacon only works for BRAF V600E mutation. There are other BRAF mutations which actually commonly have a better prognosis. You know, they make tumors not as aggressive. So this 469 mutation is not the right mutation for the Beacon regimen, neither doublet nor triplet. So this would not work. Tumors don't change from MSS to MSI. And the status should be tested, actually routine testing right up front, initial diagnosis. Every patient with colon cancer and rectal cancer, independent of stage and age, should have their cancer tested for MSI status right up front. So this is something which is part of the routine testing. Again, another question about the G469. I don't believe that this is the right approach to use the Beacon regimen in these non-V600E mutant tumors. Okay, what else do we have? Nothing. So everyone's excited about immunotherapy, of course, but localized radiation to rego-nivo. You know, it's the question of abscopal effect. Whether this is really, whether it really exists is still debatable. Abscopal effects have only been shown in tumors that are highly immunogenic to begin with, meaning in melanoma, for instance. There's some data in renal cell cancer, which we know are immunogenic tumors. So I'm a little bit hesitant to embrace this idea of abscopal effects. And you know, there have been trials and studies to look at radiation of one area or ablation of one area. Let me backtrack a little bit and explain what an abscopal effect is. The abscopal effect relies on the idea that in a tumor where we have, let's say, 2 or 3 different areas of metastasis, when you radiate or ablate or destroy one metastasis locally, that the destruction of the tumor releases antigens that the immune system can recognize and then react against a different site of metastasis. For instance, if we, let's say, radiate a liver metastasis, that then lung metastasis would disappear because the immune system would be activated by this shedding of antigens. Now, again, this has not yet been clearly confirmed in most other cancers outside of melanoma. So it's part of a study approaches right now. But more and more, we see that this abscopal effect is just a theory for most cancers and not reality. So I'd be hesitant to put too much money on that. Okay, I think I answered these pertinent questions. Let's move on.
Great,
okay.
Thank you.
So, I mean, the last part that I like to talk about is a question that has come up, and I have unfortunately not as pretty slides as before because I had to really take pictures from the slides. It was the question of, does it make sense to resect a primary tumor in patients who have stage 4 disease? And this is something that has been floating around for quite some time because there are analyses, retrospective analysis, meaning not controlled studies, but just looking at the data that showed in patients who have metastasis, stage 4 disease, that the resection of a primary tumor somewhere in the colon was actually associated with survival benefit. And of course, we wrapped our head around, why would that be? Because we also know from an American study in about 100 patients that these primary tumors normally do not present a local problem like bleeding or obstruction that would require them to be removed in a stage 4 setting. Only about 8% of patients will ever need to have their primary tumor removed when they get treated with chemotherapy for their stage 4 disease. Now, there's also a bias, of course. I mean, who are these patients who get their primary tumor removed? Those patients are potentially healthier, more active, etc. So it really required a prospective randomized trial, tumor resection or no tumor resection. So it's a surgical trial And surgical trials are not easy to conduct, very difficult to conduct, especially randomized trials. And the Japanese study group here was actually able to do that. So they had primary tumor resection followed by chemotherapy, or just giving chemotherapy. The standard of care, what we're using, is to just give chemotherapy, kind of pay attention to the primary tumor. But if the primary tumor doesn't have any symptoms, we would normally not address it and would rely on chemotherapy. So they actually did do that. They did run the study, tumor resection versus, followed by chemo versus chemo alone. It was mainly FOLFOX, CAPOX plus bevacizumab, which is the most commonly used treatment in the United States. And, the study didn't completely meet the accrual they wanted because they had to stop a little bit early. But in the end, it was actually also a data safety monitoring board that showed it doesn't make sense to remove the primary tumor. So chemotherapy up front, and again, paying attention to the primary tumor, but really not doing surgery, delaying chemotherapy, etc., is the right way to go. So there's no difference in outcome in patients, and actually, neither in progression-free survival, overall survival. There are actually some patients who died from resection who we, of course, would like to avoid. So these 3 patients who had their primary tumor removed, had unfortunately didn't survive the surgery, they would have clearly been much better off with chemotherapy up front. So very important message for us, and I think this reinforces our clinical practice. In stage 4 disease, it's really the medical therapy, the chemotherapy that we rely on, and that should be embraced up front. Let me put a little side note on there, because the management of a primary tumor is sometimes critical, and to some degree. So I see sometimes when patients get diagnosed with colon cancer, and during the colonoscopy, a gastroenterologist sees an obstruction. Then a stent is put into the colon, meaning a little mesh, kind of a self-expanding mesh, a metal stent, which then gets, opens the colon. The problem is, when a stent is placed into a colon, it's a contraindication for bevacizumab, for Avastin. We know that patients who have a colon stent and get Avastin have a 20% risk of bowel perforation. Normally, the risk of bowel perforation is about 2% or even less when we select patients right. But the presence of a stent means we have a perforation 1 out of 5 patients, and that is not acceptable. So in patients who have a stent, I normally avoid bevacizumab, or I actually tell the surgeon, can you remove this piece? Because you can't pull the stent out. The stent becomes part of the colon, gets ingrown, and can only be removed by resecting this part of the colon that the stent has, including the primary tumor. And I discourage our endoscopists, our gastroenterologists, from putting stents in place in stage 4 situations where we need all the active drugs at hand. And I would not want to lose a treatment options like bevacizumab, Avastin in my patient with metastatic disease just because they have a stent in place. If there's an obstruction and we need chemotherapy, it's better to divert, kind of form an ostomy, for instance, or even resect the primary tumor if we can't do that. So local problem needs local therapy. Okay, so my last slide here, and then we can have a little bit of a question and answer session again. Molecular profiling is here to stay. I mean, this is really going to, has changed the field of colorectal cancer. We have identified subgroups that really warrant specific interventions. We even have seen tissue and organ independent drug approvals, for instance, for MSI high tumors. And the question of when should be tested is very well placed for MSI high or mismatch repair deficiency, this Lynch syndrome-like signature. Early on, we need to know upfront what's going on. When we separate cancers out now into BRAF mutant tumors, MSI high tumors, HER2 positive disease, NTRK positive disease, etc., we're turning common cancers like colorectal cancer into a collection of rare diseases, and we need to pay attention to how can we design our clinical trials. The regorafenib nivolumab data show that augmented immunotherapy can be real, and there is, I think, hope for patients with the non-immune responsive tumors to eventually benefit from immunotherapy. Whether this is the regorafenib nivolumab combination or something else remains to be seen. We need more data. And then coming back to the very first part of the presentation, circulating tumor DNA will change the way how we diagnose and treat cancer patients, in particular selection for adjuvant therapy after resection of the primary tumor, and also guiding decisions in stage 4 disease when we move from line to line of therapy. We should and we are paying more and more attention to the the alteration, the molecular structure of cancer cells that we can pick up with circulating tumor DNA. Okay, so that is what I had for my presentation. And I'll be happy to field more questions if there are questions.
Thank you so much, Dr. Grothey. If anyone has any remaining questions, please type them into the chat box. We have just a couple more minutes to address those questions. And there are social media ways, Twitter et al., to continue to engage in discussions and questions. Yes, I learn a lot from these discussions, actually. And additionally, if you do have questions that we're unable to address right now, if we run out of time, we can also follow up with a blog on the Fight CRC website. And again, Twitter is a great way to engage with Dr. Grothey and Fight CRC as well.
So there's a question here right now about oligometastatic colorectal cancer, liver metastasis, for instance. And yes, the 5-year survival rates are about, 60, 70%, but it's a little bit misleading to think that 5-year survival means that all patients are cured. So when we look at the best data we have with liver metastasis and resection, even if it's not a lot of metastasis, like in the initial study when only 4 liver lesions were allowed to be in this study, the cure, meaning patients will never have a recurrence after liver resection, is only about 25 to 30%. The patients, when we talk about 5-year survival rate of 50, 60, 70%, which are real, it is, patients might have a resection of their disease, but then they might have a recurrence 2 years later, are on chemotherapy, or have a re-resection, etc. So yes, patients are alive at 5 years with 60, 70% probability, but they might be alive with cancer. We can keep patients alive with cancer, turning cancer into chronic disease. So 5-year overall survival rate of 60 to 70%, which are real, doesn't mean it's 60, 70% cure rate, unfortunately. The cure rate after liver removal of resection, metastasis, is only 25 to 30%, but it's real. So this is something we should never forget to offer to our patients. There was a question from Sweden.
Well, thank you so much, Dr. Grothey, for a wonderful presentation. And thank you to everyone who was able to join us live today. Again, the webinar is being recorded and will live on the Fight CRC website. So please go back and rewatch and ask any questions, via the Fight CRC website or again on social media. And we'd be happy to address those and forward them along to Dr. Grothey. So Dr. Grothey, thank you again.
Thank you.
And have a wonderful day, everyone.
Bye-bye.